This recorded lecture will be going over Chapter 34, Care of Patients with Disorders of the Urinary System. Cystitis is an inflammation of the urinary bladder. It is one of the most common urinary tract infections in women because the female urethra is shorter and the urinary meatus is exposed to contamination from the vagina and anus. The E. coli bacterium normally resides in the intestinal tract as a non-pathogenic microorganism. It accounts for about 80% of all UTIs in females. Cystitis and urethritis, the inflammation of the urethra, are common in women after they have become sexually active. Honeymoon cystitis is a term sometimes used to refer to bacteria that have entered the urethra by way of friction during intercourse. Urine that sits in the bladder provides a good medium for bacterial growth. Restricting fluid intake decreases urine flow and makes the person more susceptible to UTI. The most common symptoms of cystitis are painful urination, frequent and urgent urination, and low back pain. Cystitis tends to recur, producing less acute symptoms such as fatigue, anorexia, and a constant feeling of pressure in the bladder region between flare-ups. The urine may appear cloudy or even bloody and have a foul smell. Urinalysis and urine cultures are used to establish a definitive diagnosis and to identify the specific causative organism. On page 811 in the red older adult care points box, you can see that confusion may be one of the first signs of cystitis or UTI in older adults. If a patient who is normally alert becomes confused, assess the urine for cloudiness, foul odor, or hematuria, and check for any other signs of infection. Treatment and nursing care of cystitis and urethritis are similar. Specific antibiotics, such as Bactrim, are used to combat infection and are combined with urinary analgesics, such as pyridium, to relieve discomfort. The patient will be encouraged to drink large amounts of fluids to flush the bladder and continue that habit once the acute symptoms have resided. Measures to relieve the discomfort include sitz baths and hot water bottles on the back or directly over the bladder region. On page 811 in the blue patient teaching box, you can read about preventing urinary tract infections. Urethritis is an inflammation of the urethra that can be caused by many different organisms. It is a common symptom of gonorrhea and should be investigated as soon as it is first noticed. On page 812 and 813, within table 34.1, you can read about some drugs commonly used for UTIs. Chemical irritation caused by the use of spermicidal jellies, bath powders, feminine hygiene sprays, and bubble bath can all contribute to urethritis. The chief symptoms of urethritis are burning, itching, frequency in voiding, and painful urination. There is a discharge that becomes increasingly more purulent if gonorrhea is present. The urinary meatus is swollen and inflamed. Diagnosis of urethritis is based on the presence of symptoms and a patient history that includes possible exposure to STIs. The treatment and nursing management for urethritis are similar to those for cystitis. Acute pyelonephritis is an infection of the kidneys. It is thought to occur when bacteria from a bladder infection travel up the ureters to infect the kidneys. A common cause of pyelonephritis is an obstruction, causing stasis of urine and stones that cause irritation of tissue. Chronic pyelonephritis is usually associated with congenital deformities in urinary anatomy and occurs primarily in children. With chronic infection and inflammation, more scar tissue develops, and eventually kidney function becomes impaired. In acute pyelonephritis, symptoms will include a high fever, chills, headache, malaise, nausea, vomiting, and pain in the flank that radiates to the thigh and genitalia. Eventually, the urine will become loaded with bacteria, blood, and pus. Diagnosis is based on manifestation of symptoms, physical assessment, and urine culture and sensitivity. Prompt treatment of cystitis and prevention of recurrence can help prevent acute pyelonephritis. Bed rest, analgesics, and antipyretics are prescribed. Sulfonamides such as Bactrim or fluoroquinolones like ciprofloxacin will be started because these drugs are effective against gram-positive and gram-negative bacteria. With chronic pyelonephritis, the patient could live for years without significant symptoms before renal damage leads to hypertension or kidney failure. Correction of obstruction, removal of stones, and prevention of stone formation are essential to correct chronic pyelonephritis and to prevent destruction and scarring of the kidney cells. Encourage fluid intake, record intake and output, monitor the urine for changes, and keep the patient comfortable. Ensure that the patient receives the appropriate antibiotics and understands the side effects to report and that the entire prescription should be completed. Glomerulonephritis is primarily seen in children and young adults and affects males more than females. It most commonly occurs about 2 to 3 weeks after a group A beta hemolytic streptococcal infection such as strep throat or impetigo. However, it can occur in response to bacterial, viral, or parasitic infections elsewhere in the body. It is an immunologic problem caused by an antigen-antibody reaction. Renal tissue becomes scarred and function is impaired. Nephritic syndrome can occur as a result of the same conditions that cause glomerulonephritis. The damaged membrane allows large particles like red blood cells and protein, which normally would be retained in the bloodstream, into the urine. A patient with acute glomerulonephritis usually becomes suddenly ill with fever, chills, flank pain, widespread edema, puffiness around the eyes, visual disturbances, and marked hypertension. Diagnosis is based on physical findings and urinalysis. Diagnostic tests include creatinine, blood BUN, and CBC. The urine may be smoky and will contain red blood cells and protein, and will have an increased specific gravity. Initial therapy includes IV methylprednisolone and cyclophosphamide. Management of symptoms may include a sodium-restricted diet if the patient has edema, and fluids may be limited if there is oliguria or anuria. A low-protein, high-carbohydrate diet also may be ordered. Plasmapheresis is a blood cleansing procedure that may be used in autoimmune disorders such as acute glomerulonephritis or myasthenia gravis. Obtain a history of past illnesses, particularly infections or autoimmune disorders such as lupus. Mental status must be checked frequently for indications of cerebral edema with increased intracranial pressure. Decreasing the work of the kidney is a primary goal in treating acute glomerulonephritis. Absolute bed rest usually is ordered until the clinical signs of hematuria, proteinuria, and hypertension are gone. If the patient responds quickly to treatment and wishes to be more active, you must emphasize the need for continued bed rest. If the patient has plasmapheresis therapy, you should monitor for bleeding at the puncture site every 2 to 4 hours. Also monitor for potential complications such as hypovolemia or electrolyte imbalance. The prognosis for acute glomerulonephritis will vary depending on the extent of permanent damage done to the kidneys or other vital organs. Chronic glomerulonephritis is the third leading cause of chronic kidney disease. Continued fibrosis within the glomerulus leads to a reduction of the glomerular filtration rate and retention of toxins. The kidney atrophies. The number of functional nephrons decreases and eventually kidney failure occurs. Generalized edema, headache associated with hypertension, fatigue, dyspnea, weight loss, loss of strength, peripheral neuropathy, and tremors are symptoms of glomerulonephritis. Some patients who develop chronic glomerulonephritis may have acute exacerbations. Diagnostic testing may be prompted by findings on a routine examination. Testing will include urinalysis, creatinine, BUN, CBC, and electrolytes. Abnormal laboratory values include proteinuria, urinary casts, elevated creatinine and BUN levels, anemia, hyperkalemia, hypermagnesemia, increased phosphorus, and decreased serum calcium and albumin. The treatment for chronic glomerulonephritis in the latent stage is primarily symptomatic, with emphasis on avoiding fatigue and infections, particularly of the upper respiratory tract. When renal failure develops, dialysis and possibly a kidney transplant are the only alternative therapies. Nephrotic syndrome sometimes occurs after the glomeruli have been damaged by glomerulonephritis or some other disease. This damage results in an increased membrane permeability and excretion of protein and decreased serum albumin. Hypoalbuminemia causes fluid to shift out of the vascular system into the body tissues, and the result is severe edema. Nephrotic syndrome is characterized by extensive proteinuria, hyperlipidemia, hypoalbuminemia, and severe edema. Facial edema, especially periorbital edema, may be present in the morning, whereas lower extremity edema is more evident at the end of the day. Ascites, which is the accumulation of serous fluid in the abdominal cavity, could also occur due to fluid retention. Diagnostic tests include urinalysis and serum tests for protein and lipids. A renal biopsy may be used to verify the diagnosis or to evaluate the extent of kidney damage. Treatment for nephrotic syndrome consists of an adequate protein, low-fat, low-sodium diet, diuretics, supplemental multiple vitamins and minerals, and antibiotics if an infection is present. Nursing care includes monitoring I&O, recording daily weight, encouraging rest, providing skin care, and encouraging compliance with dietary and medication regimen. Whenever the normal flow of urine is obstructed, there is a potential backward flow of fluid into the renal pelvis. Hydronephrosis occurs if the obstruction is not resolved. The renal pelvis and ureters will become dilated and continue to fill with fluid. Hydronephrosis may be unilateral or bilateral. Severe pain is present only if hydronephrosis develops rapidly. Otherwise, there are no outstanding symptoms, and the patient may develop signs of kidney failure only after serious damage has occurred. A definitive diagnosis is obtained by extensive urologic examination and ultrasound. The primary goal of treatment for hydronephrosis is to remove the obstruction so that the kidney can drain properly. Nephrostomy is a percutaneous procedure that places a drainage tube into a kidney. The nephrostomy tube will stay in place to drain the kidneys while the surgical repair site heals. It is also used to drain purulent material from an infected kidney. If the damage is irreparable, surgery is necessary to remove the kidney, known as a nephrectomy. When the patient returns from surgery, you must carefully check for the location of the surgical wounds and the presence of any drains or tubes that may have been inserted during the operation. Nursing interventions will focus on promoting an unimpeded urine flow by properly caring for catheters and tubes. Hemorrhage is a danger after surgery of the kidney because the kidneys have a very rich supply of blood directly from the aorta and vena cava. Adequate drainage from the opposite kidney after surgery is of great importance. Urinary output must be measured very carefully and recorded. Adequate pain control and early mobilization can all help prevent complications. The renal artery can become blocked or narrowed, known as renal stenosis, due to atherosclerosis or scarring. This blockage can result in hypertension or chronic renal failure. BP should be monitored. MRI, CT scan, or ultrasound could show a decreased kidney size. Balloon angioplasty or stent placement can improve blood flow to the kidney. The continuous activation of the renin-angiotensin-aldosterone system keeps the blood pressure elevated until the obstruction is resolved. A renal or kidney stone, known as lithiasis, is a crystalline mass that forms in the urinary system and, depending on the size and location, could obstruct the flow of urine. Stones can be as small as a grain of sand or large enough to fill the renal pelvis. Renal stones also vary in composition and in the environment in which they form. There are four major types of renal stones, one of which is hereditary. On page 817, Table 34.2 shows the risk factors and dietary interventions for each type of renal stone. Certain conditions will predispose a person to having renal calculi. Among the most causative factors are bariatric surgery, short bowel syndrome, or other conditions that decrease oxalate absorption in the gut. Inadequate fluid intake, which results in concentrated urine and inadequate flushing of the urinary tract, sluggish flow of urine, as may occur with bed rest or immobility, and diabetes, obesity, gout, and hypertension. The most common type of stone is formed from calcium oxalate and less often calcium phosphate. Risk factors for kidney stone formation include being of male gender, a family history of renal stones, immobility for any reason, and a history of recurrent UTIs. Ideally, adults must put out at least 2,500 milliliters of urine every 24 hours to prevent stone formation. Likewise, preventing urinary infections and maintaining adequate drainage through tubes and catheters is also necessary. Changing the urine pH can prevent or reduce the incidence of renal calculi. Some renal stones do not cause noticeable symptoms and can be passed without the person being aware of them. The kidney stones that cause severe pain are those that are small enough to move along the ureter with the urine. As the stone rolls along, sharp little spikes will scrape the ureteral lining, causing excruciating pain and bleeding. Pain is typically felt in the flank, over the affected kidney and ureter, and radiates downward towards the genitalia and inner thigh. Moving stones can get trapped along the ureter, causing obstruction of flow and swelling of the ureter. Diagnostic tests include a low radiation dose non-contrast CT of the abdomen and pelvis, or an ultrasound. Urinalysis will identify whether blood, albumin, or other characteristics are present. At first, the healthcare provider may try to flush the stone out by increasing the patient's IV fluids or oral intake and managing pain by prescribing opioid analgesics or NSAIDs, as well as antispasmodics such as probanthine or ditropan. Medical expulsive therapy, also known as MET, is tried first with alpha blockers such as Flomax. When the stone is not passed spontaneously, cystoscopy or surgical intervention is necessary. Stones can be removed directly during ureteroscopy and ureteral stents placed if indicated. PNL is indicated when shock wave lithotripsy, or SWL, has not been effective. SWL is performed in an operating room where high energy sound waves are generated and focused on the stone, pass through a water-filled cushion and break the stone. MET therapy is used as an adjunct to SWL and increases the rate of stone passage. If the stone is 5 millimeters or larger, the patient may also receive a ureteral stent. This is a soft, flexible silicone tube, which is inserted through a cystoscope or nephrostomy tube or during surgery. The purpose of a ureteral stent is to maintain the patency of the ureter to allow the stones to pass through. On page 818 within Table 34.3, you can read about some common catheters and tubes that are used for urologic disorders. During the initial assessment of a patient with kidney stones, the patient may have extreme pain, so use concise questions to gather information. Attempts are made to have the patient pass the stone spontaneously, and all urine should be strained to recover the stone or fragments for analysis. Fluids are encouraged during this time to facilitate flushing of the stone. After PNL, a fluid intake of 3,000 to 4,000 milliliters per day is required to flush any residual stone fragments out of the kidney. After an SWL procedure, the patient may experience cramping pain and can be given opioid pain medications. After any invasive intervention, nursing actions will include monitoring for infection, bleeding, urine output, and pain. Blood in the urine should be expected after any procedure on the urinary tract. Accidental injury to the kidneys, ureters, bladder, or urethra should always be considered whenever there has been trauma to the abdominal cavity, lower back, or thoracic cage. Injury to the kidneys is usually caused by blunt trauma that is sustained during a motor vehicle, sports, or occupational accident. Ureteral injuries are mostly associated with penetrating trauma. Signs and symptoms characteristic of trauma to the kidneys include bruising, hematuria, abdominal or flank pain, and possibly an enlarged mass in the kidney area. Diagnostic tests include serial urinalysis, hemoglobin and hematocrit tests, and measurements of electrolytes. Radiologic studies such as a KUB, IVP, or CT scan can demonstrate the extent of damage to the urinary system. Bleeding in the kidney is often self-limiting. The nephrologist may advocate for a period of watchful waiting to see whether the kidney can be saved. If the kidney is severely damaged, the patient may undergo a nephrectomy. A comprehensive plan for dealing with problems associated with multiple trauma is necessary. Preoperatively, the patient will be monitored closely for signs of hypovolemic shock, cardiovascular changes, urinary output, and the size of the flank hematoma. An indwelling catheter will allow for close observation of urinary output. Any violent blow or crushing injury to the lower abdomen may result in rupture or perforation of the bladder wall, with resulting leakage of the urine into the pelvic tissues or peritoneal cavity. This results in severe inflammation or peritonitis. Early symptoms of bladder injury are painful hematuria or inability to void, marked tenderness and spasm in the suprapubic area, or the development of a large mass in that area. Diagnosis is based on the presence of gross hematuria, suprapubic pain, and difficulty voiding. Patient care requires meticulous attention to drains and dressings to prevent infection and maintain good drainage. Cold applications to the surgical site, both before and after surgery, may be ordered. Any mass formation in the suprapubic area before or after surgery, or any changes in vital signs, should be reported immediately. Bladder cancer is more common in men aged 60 to 80 years old than in women. Smokers have double the risk of developing this cancer. People living in urban areas or with occupational exposure to nitrates, dyes, rubber, or leather processing are at a higher risk. Bladder tumors are removed even though they are papillomas because there is a high risk for invasion into the deeper tissues and metastasis. The main symptom of a bladder tumor is hematuria. Frequency, urgency, or dysuria also may be present. Diagnosis is confirmed by examining the bladder wall with a cystoscope and biopsy of the tumor. Treatment for bladder cancer is surgery, either alone or in combination with chemotherapy or radiation. The type of surgical treatment will depend on the clinical stage of the tumor. The drugs that are used most often for intravesical therapy are mitomycin and thiotepa, but combinations of other drugs like valrubicin, doxorubicin, and gemcitabine could also be used. BCG was originally used as a vaccine against tuberculosis. It has helped patients with bladder carcinoma in situ by reducing tumor recurrence and eliminating residual malignant cells after surgery. The solution is instilled into the bladder via a urinary catheter. The catheter is then clamped for 2 hours, and the patient's position should be changed every 15 to 30 minutes. Photodynamic therapy can also be used for superficial tumors. Bladder surgery can be minor, such as removing polyps from the bladder interior using a cystoscope, or major, such as a cystectomy, or partial cystectomy for bladder cancer. After cystectomy, there is always the danger of hemorrhage and infection. When the bladder is surgically removed, the surgeon will perform a urinary diversion to handle the excretion of urine and create an artificial opening or stoma on the skin surface. Diversions can be continent or non-continent. Urinary diversion can be accomplished in several ways. This can include ileal conduit or ileal loop, ureterosigmoidoscopy, or sigmoid conduit and ileal reservoir. In a cutaneous ureterostomy, the surgeon will detach one or both of the ureters from the bladder and bring them to the surface of the body, usually in the region of the flank. Any urostomy bags or tubing leading from the ureterostomy should be kept open so that urine can flow freely. An ileal conduit is also called a urinary ileostomy and ileal loop, or a Bricker procedure. A portion of the ileum is used as a tube or conduit through which urine flows to the outside. The ureters are attached to the ileal conduit so that urine can flow through the conduit to the outside. A sigmoid or colonic conduit uses the sigmoid colon as the insertion site for the ureters, and urine is expelled with stool. Due to the potential for incontinence and other complications, currently this procedure is rarely performed. Typically, either an ileum or terminal ileum combined with ascending colon can be used for a continent urinary diversion. Bladder substitutes or neobladders can be created using a portion of the patient's own intestine. They can be used when the sphincter is intact and there is no cancer in the urethra or bladder neck. The advantage is normal micturition. Emptying of the surgically created bladders is accomplished by tightening the abdominal muscles. These images can be seen on page 822. After surgery, observe for pain, abdominal rigidity, fever, and bleeding. Assess the amount and characteristics of the urine and mucus, and record accurate output of urine every hour for the first 24 hours and then every 4 to 8 hours. The bowel tissue used for construction of the bladder will produce mucus, so irrigation of the catheter is necessary to prevent blockage of the catheter. Regardless of which surgical procedure the patient has had, the urine should never stop flowing. The urine should initially be light red or pink and progress to clear within 3 days or less. Bright red bleeding or clots should be reported immediately. The stoma should be pink or red. A well-fitted and properly adhering collection appliance is essential. The bag should be emptied when it becomes 1/3 to 1/2 full to prevent the weight of the urine from pulling the bag loose. A bath or shower may be taken with the bag on or off. Most appliances contain an odor barrier. However, odor may be a problem due to poor hygiene, alkaline urine, normal breakdown of urine when it is exposed to air, and the ingestion of certain foods like asparagus. Psychological care of a patient facing malignancy and an operation that will radically change their body image should be a primary nursing concern, and there are always sexual concerns when a urinary diversion is performed. Cancer of the kidney, known as renal cancer or renal cell carcinoma, is relatively uncommon in people under the age of 45. People with kidney cancer tend to be older and many times have other health problems, so treatment and predicting survival rates are complicated. Risk factors include smoking, obesity, hypertension, and exposure to cadmium, asbestos, or petroleum byproducts. More than 25% of patients are asymptomatic, and their cancer was found when imaging studies were done for some other reason. The classic symptoms of hematuria, palpable abdominal or flank mass, and flank pain are frequently not present. Other symptoms that could occur are fever, fatigue, weight loss, decreased appetite, and hypertension. CT and MRI are the imaging studies most commonly used to identify RCC. Surgical removal or partial removal of the affected kidney is curative in non-metastatic disease. Immunotherapy, targeted therapy, and radiation are used for RCC with metastasis. Cytokines interleukin 2 and interferon alpha are immunotherapies that are effective for only a small percentage of patients. Targeted drug therapies for advanced kidney cancer will act to deprive the tumor cells of its blood and nutrients. Chemotherapy is not a standard treatment for renal cancer because kidney cancer cells are usually resistant. Nursing care of patients with renal cancer after nephrectomy is the same for that as of any other cancer patient. Renal failure is the inability of the kidneys to maintain normal function. Renal failure is classified as acute or chronic. The final stage of chronic and irreversible renal failure is called end-stage renal disease. Acute renal failure or acute kidney injury occurs suddenly as a result of physical injury, usually secondary to hypoperfusion, infection, inflammation, or damage from toxic chemicals. Nephrotoxic agents can inflict damage on the renal tubules, causing acute tubular necrosis and loss of function. They can also indirectly harm the tubules by causing severe constriction of blood vessels that serve the kidney, producing renal ischemia. ATN is responsible for 90% of ARF. Acute kidney injury is diagnosed when there is a sudden decline in GFR. There are causes of AKI. Pre-renal AKI is caused by a decreased blood flow, such as in hypovolemia, or decreased cardiac output, like cardiogenic shock. Intrarenal or intrinsic AKI results from glomerular damage, ATN caused by toxins like medications, or vascular disease that affects the vessels in the kidneys. Postrenal or obstructive AKI is caused by obstruction in the ureters, bladder, or urethra. It causes eventual backflow of urine into the kidney, which in turn leads to tissue damage. AKI is potentially reversible, especially if identified early. Patients could often regain their kidney function. The course of AKI or ATN can be divided into 4 phases: onset, oliguric, diuretic, and recovery phases. The onset phase lasts from hours to days and begins when the kidneys sustain injury due to one of 3 mechanisms listed above. In the oliguric phase, the patient will put out 100 to 400 milliliters of urine in 24 hours. The diuretic phase occurs only as the kidneys regain their function. The recovery phase begins as kidney function starts to normalize. Renal failure will affect the entire body, and the signs and symptoms will vary according to the phase and response to treatment. Carefully observe your patient for any of the following symptoms: changes in urine output and urine results, electrolyte imbalances, fluid imbalance, acid-base imbalance, GI effects, mental status changes, anemia and platelet dysfunction, and impaired wound healing and susceptibility to infection. Diagnostic testing includes urinalysis, creatinine, BUN, CBC, and electrolytes. There are several staging systems for AKI, with RIFLE being the most widely used to identify the degree of injury. The acronym stands for R, risk, I, injury, F, failure, L, loss of function, and E, end-stage renal disease. Each stage is defined by GFR or urine output and/or the need for dialysis. Treatment of ARF is aimed toward correcting the underlying cause and preventing or controlling complications until the kidneys can recover and resume their normal functions. Symptomatic treatment includes the correction of fluid and electrolyte imbalances, management of anemia and hypertension, and cleansing of the blood tissues for waste products with hemodialysis or peritoneal dialysis. Volume overload can be treated with diuretics and fluid restriction. Other problems include dietary needs, anemia, and the potential for infection. Renal replacement therapies consist of intermittent hemodialysis, peritoneal dialysis, and continuous hemofiltration. When taking a patient's history, include questions that relate to fluid imbalance and any potential risk factors. Acutely ill patients who are at risk for AKI will need frequent reassessment for signs of fluid retention and for imbalances of electrolytes. Carefully monitor for signs of fluid imbalance. This includes a physical assessment of edema, daily weights, and lung sounds. Strict measurement of I&O is essential. Equipment such as IV control pumps should be used for accurate and safe delivery of IV fluids. Electrolytes should be monitored and may manifest as changes in the patient's mental status or cardiac dysrhythmias. To prevent infection, be vigilant for signs and symptoms of infection. Surgical aseptic technique should be used for procedures such as Foley catheter insertion and central line dressing changes. If there are sudden changes or if the hourly urine output drops below 30 milliliters per hour, the healthcare provider must be notified immediately. The patient should be assessed for signs of worsening, such as shortness of breath and lung crackles associated with pulmonary edema or decreased cardiac output associated with heart failure. This concept map can be seen on page 824. Chronic renal failure is a progressive loss of kidney function that develops over many months or years. CRF is caused by destruction of the nephrons. All of the factors that can cause AKI can also cause CRF. The most common causes of CRF are diabetes and hypertension. Nephrosclerosis results from hypertension and causes atherosclerotic disease of the small arteries in the kidneys. As the blood supply decreases, the kidney cells degenerate and lose their ability to function, resulting in end-stage renal disease. BUN and creatinine will start to increase after the GFR has decreased to 50%. The patient will not experience symptoms until about 65% of the kidney tissue has been damaged. In the final or end stage of renal failure, 90% or more kidney function is lost. Azotemia is the accumulation of nitrogenous products, which is signaled by an increase in BUN and serum creatinine. There are 5 stages of CRF, all defined by their GFR. A normal GFR is 125 milliliters per minute. In stage 1 GFR, it is greater than 90 milliliters per minute. There is a diminished renal reserve, but no accumulation of metabolic waste. In stage 2, GFR is between 60 and 89 milliliters per minute. There is renal insufficiency and more kidney damage has occurred. In stage 3, GFR is between 30 and 59 milliliters per minute. BUN and creatinine will elevate, edema can occur, and there is a decreased urine output. In stage 4, GFR is between 15 and 30 milliliters per minute. BUN and creatinine will continue to elevate, anemia may develop, and discussions about dialysis or kidney transplantation should occur. In stage 5, GFR will be less than 15 milliliters per minute. This is end-stage renal disease. This image can be seen on page 828. The symptoms of CRF do not appear early in the disease. A high normal elevation of creatinine is an early warning sign, but the patient is usually asymptomatic. In stage 3 kidney failure, symptoms such as uremia or uremic syndrome, like headaches, nausea, weight loss, and fatigue, will occur. As renal failure progresses, the kidneys may not be able to produce much urine at all, and oliguria and eventually anuria develop. Untreated uremia leads to dry, scaly skin with a pallid yellowish-gray color. Pruritus occurs. Calcium is not absorbed from the intestinal tract, and this leads to the loss of calcium from the body and a corresponding drop in serum calcium. The patient is hypertensive from fluid overload, and the kidney sending out renin to try to increase blood flow. Anemia is present due to the decreased production of erythropoietin. Constipation from drug therapy and fluid restriction is common. When circulating wastes are increased, the nervous system cells become irritated, and the patient could have an altered level of consciousness. Creatinine clearance is a good measure of GFR. Urine will be collected over a 24-hour period. Based on the GFR, creatinine, and urine output, a diagnosis is made. A renal ultrasound, renal scan, CT scan, and renal biopsy are additional diagnostic tests that will not confirm this diagnosis, but help with identifying the causes and contributing factors. Medical treatment and nursing intervention include measures to correct fluid and electrolyte imbalance and acid-base imbalance. Controlling diabetes, hypertension, or other underlying diseases can also slow progression of kidney injury. Diuretics can be used while there is still some remaining kidney function, but are not useful during end-stage renal disease. Dialysis and kidney transplantation are the two treatments available for patients with end-stage renal disease. Hemodialysis and peritoneal dialysis will rely on diffusion and osmosis to remove waste elements normally excreted in the urine. During hemodialysis, blood moves from the arterial circulation through a dialysate bath and back into the venous circulation. A temporary access for hemodialysis can be achieved by inserting a jugular or femoral vein dialysis catheter. On page 829, you can read about some common drugs used to treat renal failure within table 34.4. Only trained dialysis staff should use the temporary access sites for medication administration or any blood draws. Two kinds of internal access are used for ongoing hemodialysis. An arteriovenous fistula can be formed by joining an artery and a vein. Although the AVF has fewer complications and better patency, it requires relatively healthy blood vessels. Therefore, patients with diabetes, prolonged IV drug use, or peripheral vascular disease may need an alternative type of access. The arteriovenous or AV graft access can be accomplished by connecting an artery and a vein with a graft of a piece of synthetic material. The hemodialysis needles will then be placed directly into the graft. Medications commonly prescribed for patients with end-stage renal disease who are undergoing dialysis will include multivitamins, antacids, iron and calcium supplements, antihypertensives, epoetin alpha, phosphate binders, and possibly anticonvulsants. The fluid shifts that occur with hemodialysis may cause muscle cramping, hypotension, nausea, and vomiting. The access may clot off, get infected, or bleed excessively after treatments. When caring for a hospitalized patient who has an AV graft or an AVF, it is important to check the site and protect it from injury. Palpate for a thrill, which is a vibration in the vessel, by gently laying your fingers on the enlarged vessel. You should be able to feel a buzz or vibration. A bruit should be clearly heard on auscultation, and the rhythm of the sound should coincide with the patient's pulse. Care should be taken to never compress the extremity containing vascular access. On page 830, see the red safety alert box. Antihypertensive drugs are not given on the morning of dialysis because they can cause severe hypotension during treatment. Nitroglycerin patches, digitalis, and anticoagulants should also be held. Consult with the dialysis nurse to coordinate the timing of medications. Post-dialysis nursing care will include monitoring the access site for bleeding for 1 hour after treatment. Monitor and compare vital signs to pretreatment values and continue assessment of the access site for patency and signs of infection. Invasive procedures will be postponed for 4 to 6 hours after dialysis because the clotting time is extended from the heparin use during dialysis and prolonged bleeding could occur. The scheduling of hemodialysis sessions will vary from patient to patient, but treatments usually are done 2 to 3 times a week on an outpatient basis at a dialysis center. Peritoneal dialysis is an alternative procedure that can be used instead of hemodialysis to remove waste products or toxins that have accumulated as a result of ARF or CRF. During peritoneal dialysis, dialyzing fluid that is equal in osmolality and similar in composition to normal body fluid will be introduced into the peritoneal cavity via a tunneled abdominal catheter by gravity. The solution is left in the peritoneal cavity for a specified time, known as the dwell time, allowing for the concentration of the solutions on either side of the peritoneal membrane to equalize. At the end of the dwell time, the dialysate solution containing waste products is drained from the abdominal cavity. The drainage should be colorless or straw-colored unless the catheter has been recently inserted. Then the drainage may be bloody for the first several treatments. Peritoneal dialysis has several advantages. The treatment can be started more quickly than hemodialysis. Anticoagulants are not necessary. Maturation of the access site and canalization of blood vessels is not required. There is less stress on the cardiovascular system because fluid exchanges occur more slowly, and some patients with renal failure will fare better with a gentler therapy. There are several types of peritoneal dialysis. The first type is continuous ambulatory peritoneal dialysis, or CAPD. The CAPD process goes on 24 hours a day, 7 days a week. As a self-dialysis method, CAPD may be the easiest for the patient and it requires no machinery. Continuous cycler peritoneal dialysis delivers 3 to 6 overnight changes. The machine is programmed to open the flow of fluid into the peritoneal cavity, then clamp for dwell, and then open the outflow into the discard bag. Nightly intermittent dialysis can be accomplished with the use of a cycler and is performed 3 to 5 times per week for 10 to 12 hours at night. This will allow for the patient to be free between treatment times. Potential complications of peritoneal dialysis include peritonitis, leakage, obstruction, or other problems with the catheter, respiratory problems, and fluid overload or hypertriglyceridemia. Nursing care for a patient undergoing peritoneal dialysis includes obtaining the patient's weight before and after treatment, maintaining careful I&O records, maintaining strict aseptic technique, and handling the dialysate bags, peritoneal catheter, and all other equipment. Monitoring vital signs, observing for complications like peritonitis, and keeping the patient as comfortable as possible. An alternative to dialysis is to transplant a kidney from a living tissue compatible donor or from a cadaver donor whose kidney tissue is compatible with that of the recipient. Tissue typing to determine donor-recipient compatibility is performed, along with extensive psychological assessment and counseling for both the live donor and the recipient. A significant factor in transplant therapy is the shortage of organs. Hypertension is brought under the best possible control. Any infection is treated, and the patient is dialyzed immediately before transplantation. There are 4 classes of immunosuppressive drugs commonly used to prevent organ rejection. This includes calcineurin inhibitors, antiproliferative agents, mammalian target of rapamycin inhibitors, and steroids. Long-term problems for transplant patients include increased susceptibility to infection, toxicities from anti-rejection medications, and a higher risk of malignancy. Renal transplant patients are transferred to critical care or specialty units after surgery, where they will be closely monitored for signs of rejection. Protection from sources of infection is a top priority. Renal failure and dialysis are very expensive for the patient and the family. Monitor BUN, serum creatinine, electrolytes, and urinalysis. As the disease progresses, assess for impaired urine concentration, decreased output, and anemia. Weight gain, peripheral edema, or the presence of a dialysis access could all alter body image or feelings of attractiveness. In planning care for a patient with a chronic renal disease, Consider the stress of prolonged intensive treatment, the frustrations of dealing with an incurable illness, rigid dietary restrictions, fatigue, malaise, occasional limited mobility, and possible sexual difficulties, all of which take their toll on the patient and the family. Daily weight, measurement of INO, determining the pattern of urination, and restricting fluid as ordered by the healthcare provider are essential to the well-being of a patient with renal damage. Because of the buildup of nitrogenous waste from protein metabolism, restriction of a protein intake is necessary. Only high-quality protein foods should be encouraged. Potassium will also be restricted. Sodium intake often is restricted, especially if the patient is hypertensive. Assess the patient's health status and learning needs throughout the illness, and provide information to manage symptoms and prevent further damage whenever possible. Goals include minimizing uremic toxicity, maintaining acceptable electrolyte levels, controlling hypertension, providing sufficient calories, and maintaining good nutritional status. Encourage communication between the patient and spouse to elicit feelings about changes in sexual activity, role reversal, and family responsibilities. A major function of nurses in the community is to assist patients who have had hypertension or diabetes to achieve good control of their disease to help prevent damage to the kidneys. Nurses can participate in community education to increase awareness of organ donation programs. Home care nurses are constantly on the alert for signs of ARF or CRF among their patients. Nurses in long-term care facilities deal with a variety of urinary problems. Bladder training for incontinence is a prime consideration. Keeping residents dry and odor-free is very important for physical and psychological reasons. Nurses who work in dialysis centers are typically the primary nurses for patients in renal failure.